All About Assessments by Mackenzie Johnson. Today we're going to review a variety of areas that OTs might utilize or do utilize within their daily life. First, we're going to review the constructs that an OT may use. This can be varying dependent on their setting, the level of measurements through which some standardized assessments may even go under. We'll go over standardized assessments and non-standardized assessments, the advantages and disadvantages, as well as an example of interviews, self-report surveys, and performance-based tests. And finally, we'll end with a patient-reported outcome measure that is related to the research that I'm currently doing. So let's begin. The constructs that OTs often use kind of vary depending upon the setting that one's working in, as you may be utilizing one area more than others, such as if you're in the school, you may be assessing fine motor, whereas outpatient, we're assessing fall risk. However, across the board, ADLs are typically always addressed. This could be done through the Barthel Index. Cognition is also something that could be assessed patient by patient, or even some settings have you do them to every patient regardless. This could be done through the BIMS, the mini-cog, or the MOCA. Fall risk is something that I see often used, and we use assessments such as the TUG, or the timed up and go, and the 30-second sit to stand. Next, we'll move on to the level of measurement. The level of measurement are nominal, ordinal, interval, and ratio. Nominal is organized patients typically by diagnostics, and there's no rank. We'll get into that in just a little bit. Ordinal, there is an order of rank, and often within OT is tied to satisfaction. Interval, again, is data with numbers, but there is no true zero. And ratio, again, numerical data, but has a true zero. So let's look at a few examples. Nominal could be characterizing individuals who have adhesive capsulitis or lateral epicondylitis. This could be across the board to hand fractures and total knees and total hips or total shoulders. Then to ordinal, clients oftentimes rank their satisfaction and care with the provider. We use the NPS where I work, which is a National Patient Satisfaction Survey, sent out to each of my patients at the end of their visit with myself. This could be satisfied, very satisfied, neutral, dissatisfied, things like that. The interval, an example of this could be utilizing the mini mental examination score, where 0 does not mean that there's a complete lack of cognition, so there is no true 0. And then ratio, on the other hand, as we mentioned, does have a true 0. We could utilize something such as the single leg stance on a person's right leg, which means that the patient was unable to balance on the right leg. Standardized assessments, it's important to know that they are formal tests that provide scores that can be compared to a baseline. There's many different kinds of assessments that us OT may use depending on the patient as well as their area that we are addressing. I previously mentioned the timed up and go. I really do see this one a lot utilized where I work, as well as the Canadian Occupational Performance Measure. Non-standardized assessments could be patient interviews or observations of a patient. What are some advantages and disadvantages of standardized assessments? So let's start with the advantages. There's less risk of bias. You're able to compare to a baseline. You have norms, and it's reliable and valid. Allows them to be trustworthy and utilized all throughout OT. Some disadvantages is you're not always seeing the patient within a natural setting. This may be during a visit where they are not comfortable or they're not doing things as they typically would, as well as the cost of assessments. Yes, many are free, but that is not always the case. Non-standardized assessments, they are gathered oftentimes in a patient's natural setting. A school, a child is observed within the classroom or their natural setting, and it can relay in-depth information about the client through these observations. Some disadvantages include the risk of bias. The OT may not observe things the way that they should be. It's also difficult to mark progress. You can do it, but it is harder. And sometimes time restraints come into play, as the time required to gather this information can be substantial. All right, now we're going to go into an example that I could do with a patient. So first is observational interviews. So we observe a patient during a visit or within their natural environment to kind of assess how they are moving or their abilities, strengths, barriers, things like that. Then we could have them complete a self-report survey where they would potentially fill out the occupational self-assessment, and we could utilize that. Then performance-based tests, so relating to the research that I'm currently doing on adhesive capsulitis and the effect of therapeutic exercise, the OT could complete active and passive range of motion to assess if a patient has a capsular pattern or limitations in motions for external rotation, abduction, and internal rotation. This would be compared to the unaffected side. Coming back to the current research that I'm doing involves the effect of therapeutic exercise on range of motion for people that have adhesive capsulitis. Patient-reported outcome measure for this would be the upper extremity short form 7A. Kind of ask the patient if they're able to carry objects above 10 pounds, and then checks different boxes. So you can review this as well. Overall, I hoped that this was beneficial for you. I enjoyed getting to explain each of the areas a little bit more.